Huge case study up here. We're going to do it on cinematic. As I was writing it, it didn't lead to the chronology that is easy to just point at stuff and go from here to there. It's basically all over the place. So let's talk a little bit, because I think there's, as usual, lots of core values. This is always less about what it is that we're actually going to do, even though that might be interesting to you. But that means you have to have my skill set and know how to do how do you, like, what wrench do I use? Or you have to have a DeWalt drill. You know? But what we can always share is the core values on how we can get to very particular touch points, at which point you can use any kind of hardware, any type of techniques, any kind of methods. But how do we get to that place, and how do we make sure that we miss as little as possible? That's the systematic approach that I want you to see and that I want to share. So 20 plus years of patellar dislocation on this individual young man, probably, by his own admission, didn't do a lot of great training or rehab, but then was able to get there over time. This is a long period of time, 20 years. Throughout early in that period of time, he had a bucket handle meniscus. So that does speak to some instability in the knee. That makes a lot of sense. What sticks out, etc., is two things. Number one, just by seeing what this quad looks like, it's still significantly different. Is it atrophied? Probably, if we compare the other side. It's not like this post-surgical primordial goo of a quad, but it's different. It's different than the other side. But even before I saw him, I was able to see the MRI that he had gotten 2 weeks ago. And the reason that he got an MRI 2 weeks ago was that he was running football routes with his son and just locked up, fell, and knee the size of a watermelon. So I think getting an MRI is crucial at that point, particularly with the history, even though 20 years, but also over this course, hey, not quite right. He was able to do some intense, CrossFit type training over a significant period of time, but again, just very little patience for any suggestion that an MRI, as long as we control how that message is carried out, there's no such thing as bad information, and information doesn't mean action. So what did we see on there? Number one, this isn't a pristine knee, but definitely not the worst you've ever seen. Number two, history of meniscectomy, and it was big. He had lost quite a bit of that meniscus. And then thirdly, there was a loose body that had likely been part of this construct that effused his knee. Over the last 2 weeks, because his knee looked pretty clean, it wasn't wet at all. Over the last 2 weeks, he would suggest that his anti-inflammatory approach was up to 8 minutes a day in the cold plunge. And I said, all right, hey, your knee is good. I don't think the cold plunge was a direct component. I think the cold plunge may have a systemic effect that might allow more biological resources to evacuate that swelling, but cold plunge doesn't really know that you have a swollen knee. And in fact, if I had a choice, I would probably pick the sauna in front of the cold plunge for a local impact, and then I would then choose hyperbaric chamber before the sauna. That being said, his knee is not swollen. So he's probably where he was 3 or 4 weeks ago. And that's all very, very sensible. Now, the other thing that's very important before we got to physical exam was his admission of a very significant stressful lifestyle. And I'm like, yeah, that matters. And we took a lot of time to talk, because part of why this is all over the place is that we went around almost 3 hours with this. And anytime I go that long with somebody, there's a lot of talking, there's a lot of planning. This individual has about a year plus of management there before he gets to where he wants to be. That doesn't mean everybody needs to do it. I think there was significant value. I don't know that I would have been able to get it done in an hour, but if I did, it would have been because there was much less talking about other types of things that will have a huge role in his overall endpoint. So that stressful piece then took us to discuss a little bit about blood work and a little bit about some of these stress markers that could very well increase sensitivity. Things like prolactin and cortisol and even the metabolic measures, they don't know that your knee had a dislocated patella and or a bucket handle meniscal tear. But what they can be a part of is how you perceive different sensory motor experiences. So to think that that's not part of this, or that's not what I do, my whole thing, that's right up there with don't get MRIs. MRIs are bad. Like to think and to think that we can't use blood work to make other types of non-pharmaceutical and non-disease pathological decisions. Wait, why not? Like I don't know why you couldn't do that, or how somehow that's wrong. How do you best decide different types of cardiovascular training models? How do you best advise or refer to other individuals, as far as that stress? And of course, where are we? A snapshot is a blood work is a snapshot where we are in this trend of other things related to the liver, related to the kidney, all of these different factors that can impact how well you integrate and absorb and adapt to stress. That took some time to discuss, but also very, very important because I also want to honor with my communication his confidence and his choice to disclose something that maybe other people think is very personal or other people think has nothing to do with it, when of course it has a lot to do with it. So moving on to a physical exam, what did we see? We're going to look at things in two different ways. We're going to look at them with the SFMA. If you don't want to use the SFMA, okay, I don't know a more efficient way to embody the core values of a keen movement screen. Number one, change positions. Look at something in as many different positions as possible. Number two, look at that same pattern or that same construct and eliminate joints from that appraisal. Number three, change the stabilization demands. We see all the time. You yank on a rubber band and all of a sudden you have this brilliant exposure of hip mobility that you didn't have before you yanked on the rubber band. Changing stabilization demands has both a mechanical and a potential neurological construct, but then active versus passive. Active versus passive, you can skip a lot of steps without missing as little as possible. I'll never say miss nothing. That's the goal. The goal is when you're really, really slick, you're going to skip steps without missing anything. That's kind of cool. But nonetheless, if I can put you on the table and I passively move every joint, that's what I was doing in like 2007 before I learned the SFM. Because what that was, that model of looking at the lowest position possible, so the stabilization is very, very minimally demanded, and then looking at passive. I'm just looking, can the joints actually do this? Well, what am I going to miss? I'm missing the speed of how I can get into training as quickly as possible because I'm not learning anything about motor skills or motor control. I'm not learning anything. And then there are going to be some compressive environments where knees don't hurt when you passively smush them, but they do hurt when they squat. And you're certainly not going to be able to appraise ankle dorsiflexion the same way you would in the closed chain. There's probably a list of things that you're leaving on the table as to why you should look at change positions, eliminate joints, active versus passive, change the stabilization demands in a vertical position. Because if you see everything you want in vertical, you don't need to waste time looking at other things. Touch your toes, pretty good. Backward bend, not his biggest issue, but some hinging in the lumbar, which of course makes a lot of sense, particularly after we find the other areas other than the knee that maybe were not painful or sort of painful. So when you have that overload at 4.5 and at 3.4, well, that kind of falls into the no shit category when someone has a history of knee issues. Poop goes up and downhill. So everything is connected when we talk about these myotomes and dermatomes and sclerotomes. Rotation was wonky, like weird. So rotation each way, just stiff and fidgety. And then if we minimize, eliminate joints, so we're kind of minimize, we can't totally eliminate pelvis, SI, 5-1, hip, knee, ankle, and then rotate. And we started to see major changes, but they didn't lead to this simple construct that, let's say, if you minimize ipsilateral lower extremity, all of a sudden they have this huge turn. Yeah, you can probably implicate its hip or at least hip and knee internal rotation. We were seeing all sorts of stuff, so we needed to look at rotation much, much clearer. Single leg stance, didn't see anything. Squat, went right to closed chain, ankle dorsiflexion, significant limitation. Opening joint symptoms through the back, that gives us a linear process. Remember, when you have closing joint symptoms, that doesn't mean you have a bone spur or something in the mortise. What it means is you just got to take a little different hunt and peck approach versus when you have the opening joint stuff, we're just going to mobilize. Shoulders, again, didn't see much, but again, similar to rotation, like when you have a lot of repetitions of seeing things, there's something's not quite right. And then to the left, rotation of the neck was limited. Okay, so now what?